Thank you to all of you for coming at this time when I know there are many competing events going on, and I'm sure your attention is flagging. And thank you for rousing yourself and coming to this session. Very, very honored. I've had such an exciting day. It's been so wonderful to meet people whose works I've read, people I've admired, to people who've shaped policy, and to hear about all the great advances that are coming down the pike. And the one word that often keeps being used is big data. Have you heard that word today a couple of times? And I wanted to share with you a slide I came across that defines big data. And if you can't read it, it says, big data is like teenage sex. Everyone talks about it. No one really knows how to do it. Everyone thinks everyone else is doing it, so everyone claims they're doing it. But I actually do know what big data looks like, because I had the great privilege of watching this paper unfold at Stanford. And it was a paper written by Mike Snyder and his group. He's the head of genetics. And it's a very unusual paper. I'm not a genetics cell big data person. Nevertheless, this paper was striking to me for reasons that I'll explain. It was titled Personal Omics Profiling Reveals Dynamic Molecular and Medical Phenotypes. That's a mouthful. And the next slide, I hope, won't scare you away, but I'll walk you through it. Basically, what they did is they studied the lead author, or the senior author, Mike Snyder, for 700-something days. And so this column here, this black line, represents the number of days that they were testing him intensively. And during the course of those 700 days, he developed an HRV infection and an RSV infection. And it turns out, because of a genetic predisposition, he became, frankly, diabetic after one of those infections. And that was captured in the course of the study. In this panel B, you'll see how they drew blood and other testing materials, and they did whole genome sequencing. They did the transcriptome, which is to say what the genome is making. They did proteome profiling, et cetera, et cetera. In fact, the very last thing there is medical lab tests. So the sort of blood tests you and I get represent just a micro fraction of what they wound up doing. And then they did these very sophisticated analyses, intense computer manipulations, to come up with this Circos plot, which again, don't let it scare you away. I've learned to be not too scared of it anymore. Let me walk you through what it shows you. On the outside, the numbers represent the chromosome. The next is an ideogram of the chromosome, those bars. Then come the deletions, the duplications, on, just so much information in time. And the most incredible thing about this study to me was, first of all, it suggested that health is so very dynamic. We're getting such a small snapshot when we see a patient in our office one time. But the most striking thing to me was this, that the data from the study was so voluminous, it eclipses the entire contents of the Library of Congress. And that is what is coming down the pike. Eric Topol, who's speaking at this meeting, I haven't seen him yet, but I know he's speaking, has this graphic which represents sort of the same thing, pointing out that over time, we are going to get so many layers of information about our patient. At one level, we'll have sort of their social connections, a social graph, if you will, and then we'll have from the different things they wear, their Fitbits and their sensors, we'll have all that data. Then we'll have their genome, the transcriptome, the proteome, the metabolome, the microbiome, the living biological teeming mass within us, which is many, many more cells than we have in our body. And then the epigenome, and then the things we're exposed to. So that's what's coming down the pike. And I must say, I'm always puzzled by how quickly this has come about. And you might think that this has been a logical, stepwise progression through human civilization, but my students are often surprised to know that the first moment that we began to look at the body and try and get meaningful information about illness was actually not in the time of Hippocrates or Galen. It was actually much more recent. I would date it, this is my personal view, with this man, Joseph Leopold Ohnbrugger, born in 1722. And in the late 1700s, he wrote about a method of examining the patient that I think represents the start of this kind of data gathering. Now, Omberger was a physician in Vienna, and his father was an innkeeper. And so he had the experience as a small child of going down to the basement of the inn and watching his father tap on the sides of casks of wine to see how much was left, where the meniscus was, so that he could reorder. And when Omberger became a physician, he began to tap on patients' chests and abdomen and was able to map out many, many different things, including fluid collections, diseases that caused organs to swell. And he wrote a book called Inventum Novum, New Invention. And this was really huge. This was the ultrasound of its day, the first moment when in life one could look inside and say there was fluid in the chest, there was fluid around the heart, that the liver was enlarged, that this was happening, that was happening. Quite remarkable. In fact, almost everything we know about percussion he described. Very little has been added to it since his time. But unfortunately for him, no one picked up on his work. In fact, he would have died without this work ever being publicized, except for a physician by the name of Corvus Art running across the work of one of Omberger's students who had referenced his master's work. And Corvus Art immediately got interested, and Corvus Art was enormously influential. In fact, I would say he was the most powerful physician in the whole of Europe for the very simple reason that he was physician to this gentleman, which gives you a lot of clout. And so Corvus Art translated the work into French, tried it out, wrote a grand introduction, and all of a sudden, percussion had arrived on the continent, and shortly thereafter in America as well. And very soon thereafter, Lennox, who was Corvus Art's okay, something's gone awry on my side. Okay. So very shortly thereafter, Lennox, who was Corvus Art's student, developed the stethoscope. I don't know if you know the story of how he developed the stethoscope, but people were listening to their patients prior to the stethoscope, and they were doing it in a very cumbersome way by putting their ear directly on the patient's chest or abdomen. And as you can imagine, from time to time, that presents great aesthetic difficulties. And so as Lennox was wrestling with this problem, he was walking through the streets of Paris, and he saw two children playing with a solid piece of wood. And one kid was scratching on one end, the other kid was listening on the other end. And Lennox thought, well, this will work. And so the first stethoscope is the one that you see depicted in his hand there, literally a solid piece of wood, which then evolved to become what it is today. And this was a very, very important moment in medicine. In fact, I would call it a watershed moment, because think about this. Prior to that time, whatever ailed you, whatever disease it was you were suffering from, whether it was diarrhea or fever or a hemorrhagic rash, you went primarily to the barber surgeon, and the barber surgeon cupped you, bled you, purged you, and while he was at it, he would pull a tooth and cut your hair long at the sides and short at the back, whatever you wanted. There was no attempt made at diagnosis. This was the function of the barber surgeon, and actually, as you probably know, the red and white barber poles and the brass receptacles are the legacy of that tradition of bleeding people, and the red and white is the bandages that were often hung out to dry. And so the moment a physician began carrying a stethoscope in their pocket, they were signaling their departure from this sort of empiric treatment to trying to make a judgment as to what was going on, what organ was affected, and then start some sort of treatment that was empiric but much more focused. And so the carrying of the stethoscope in the pocket was a huge moment. I should just tell you parenthetically that I like to see it in the pocket. Something about seeing young physicians draping it around their necks bothers me. I don't know why. To me, it signals in elevators that you are highly eligible for marriage, you have many cows and properties. It says nothing about your skills with the instrument. In fact, I think there's an inverse correlation for the most part. But the carrying of the stethoscope was that moment in time when we began to really collect data on patients, prognosticate based on that. And It was followed very quickly by the blood pressure cuff, by the thermometer, by the development of the reflex hammer, the ophthalmoscope, many, many other sort of tools for bedside diagnosis. And this painting, to me, is from that era, from the era when the skill levels of physicians who were able to do this was quite amazing. Think of Joseph Bell, who inspired Conan Doyle to write the Sherlock Holmes stories. Joseph Bell was extraordinary, but he was probably no different than physicians on both sides of the Atlantic who had this skill of really mining the patient's body for information. And in fact, Conan Doyle, writing in The Lancet, talked about what it was like to be Joseph Bell's student and how Bell would be seated in the outpatient department in Edinburgh, students standing all around him and patients being brought in, and how a woman came in with a child and she said, "Good morning," and Bell says, "Good morning, and what sort of crossing did you have on the ferry from Burnt Island?" And she says, "It was good." And he says, "And what did you do with the other child?" And she says, "Well, I left my other child with my sister in Leith." And he says, "And did you take the shortcut down Inverleith Road to come here today?" And she says, "Yes, I did." And then he says, "And are you still working at the linoleum factory?" And she says, "Yes." To the students, this is pure magic. And then he goes on to explain. He says, "When she said, 'Good morning,' I picked up her Fife accent. And the nearest ferry crossing from Fife is the ferry at Burnt Island. Secondly, you notice that the coat she's carrying is too small for the child who's with her, and therefore she set out on this journey with 2 children, but dropped one off along the way. Thirdly, you notice that the mud on the clay, on the soles of her feet, that red clay, is not to be found within 100 miles of Edinburgh, except in the botanical gardens. And Inverleith Row is her shortcut down here from the ferry crossing. And finally, you notice the dermatitis on the fingers of her right hand. Such a dermatitis is only to be found in the linoleum factory workers of Fife. I don't know about you, but my students love this story. This is why they came to medicine, the sense that they would one day develop the skill. And as I'm about to tell you, they're often disappointed to find things have moved in another direction. So this painting, to me, signifies the pinnacle of that era. And I should tell you a little bit about it. Luke Fields was commissioned by Tate of the Tate Gallery to paint a painting of social importance, to put on record the status of the doctor in our time. Or rather, that was Luke Fields' goal when he was given the challenge. He said, "I'm going to put on record the status of the doctor in our time." And he was moved to do so because his 8-year-old son, Philip, had died on Christmas Eve. And he wanted to pay tribute to the doctor who had held vigil in the week before his son died. And I'll just take you through the painting, which you probably know. It's the most famous, iconic painting in medicine, The Doctor. And as you can see, the central space is occupied by a very sick child. Something about the posture of the hand suggests that this child is moribund, is quite ill. And the child is on 2 dining room chairs which have been pulled in. So the child probably sleeps on a straw pallet in the back of this fisherman's cottage. And then on the other side you have the parents, and you can see them, the mother's praying and the father's looking anxiously, waiting for the doctor's face to give some sign of where this is headed. And then you have the doctor, and one of the most interesting things about the doctor here is what he's not carrying. Luke Fields deliberately chose to leave out the stethoscope, the ophthalmoscope, the blood pressure cuff, all the accoutrements of that era, not to distract from the focus on the doctor. And this painting caught the public's attention, perhaps because it was one of the first of a series of paintings about social themes as opposed to, Greek gods and biblical themes. It was hugely popular. It was made into postage stamps in 10 or 12 countries. It became also infamous. Jim, you probably know this story, but the American Medical Association, well before your era, wanted to torpedo Truman's campaign to introduce socialized medicine. And they did so by printing 60,000 copies of this poster and putting it in doctors' offices with the logo, "Keep politics out of this picture, don't let the government take the doctor out of this picture." It was really the first successful smear campaign, and it really worked very well. Socialized medicine was torpedoed. And by contrast, the same image was used to celebrate 50 years of the National Health Service in England, so quite a contrast. And there's been so much written about what this painting means, and I must tell you that I actually disagree with most of the interpretations. I think that this painting, despite the title The Doctor, isn't about the doctor. This painting is about you and I, you and me, projecting ourselves into the role of that sick child. And if that's who we are, this is the sort of attentiveness we want from the physician caring for us. That's what I think this painting means. In fact, it calls to mind the lines in the Bible, for example, but actually any biblical text. But in the Bible, there are the lines, I was ill and you cared for me. I was naked and you clothed me. I was hungry and you fed me. It speaks to the Samaritan function of being a physician. And it resonates very, very strongly with the public. And I've often wondered, what would Luke Fields have done had he been commissioned to paint the doctor in our time now, in 2015? What would that have looked like? And my fear is that it would have looked like this. Because it's very clear that our attention has shifted. That the locus of our attention is the data, not so much the body who owns the data, so to speak. And I wanted to share with you these two pictures of medical rounds in two different eras. So on the top left is Maxwell Finland, a giant in infectious disease, rounding at Boston City Hospital. This is many years before I was an infectious disease fellow there. Around the bed you can see some of the who's who of infectious disease, Morton Schwartz from the Mass General and Jack Remington and others. And as you can see, the focus was the patient, and the data set was largely the patient and a few bodily emanations that were studied and which the house staff probably had right there to report. And contrast that with the bottom right, where my sense is that very often, despite the name rounds, rounds are not taking place at all. They really are a kind of card flip, a data sorting that take place quite remotely from the patient. And we might ask, does this matter? Perhaps this is the way things have to be. And I'd like to argue, and I'd love to hear your thoughts when we get to the end of this and have time. I'd love to hear your thoughts, but I would argue that it still matters that we engage with the patient physically. And I'm going to give you 3 reasons why, and I'll expound on them a little bit. The first is the reason for what I call the low-hanging fruit, the stuff you'll miss if you don't be with the patient this way. The second has to do with physician satisfaction. It's hard to be happy practicing, for example, my specialty, internal medicine, if the bulk of your time is spent in front of a screen. And the third reason has to do, most importantly, our patients and the need for this very, very sacred and important ritual. And I'm going to expound on that a little bit, all those 3 things. Let me begin with the low-hanging fruit. This is a cartoon that I commissioned. I described to the cartoonist what I wanted, and as you can see, here's a man who has an ocean liner that's run through him, and the caption says, let's get a CAT scan and consult a gastroenterologist and figure out why you're having these pains. Obviously, I'm being facetious, but the fact is that we are missing fairly obvious things when we don't examine the patient. We have a study about to be published in the American Journal of Medicine where we solicited from physicians anecdotes of a kind of error that no one else would know about. We asked them to tell us about oversights in the physical exam that led to diagnostic delay, diagnostic error, therapeutic misadventure, even surgical misadventure. And we collected 204 anecdotes, and the common theme was the exam wasn't done. In fact, if I were to make a checklist from that paper, what we should do, what we've learned, one of the themes would be patients have both fronts and backs. And if you only examine the front, you're destined to miss maybe 50% of the important things. The second caveat I'd put in there is that anybody with abdominal pain needs to have their hernial orifices, their genitalia examined. And anybody with fever needs to have all their clothes taken off, and you look carefully for rashes. But the bottom line, the most common oversight was simply that the exam wasn't done. It wasn't done. Something was done based on a lab result, based on an impression. So low-hanging fruit is one reason why we should keep at this. The second reason, as I mentioned, is the widespread problem of physician burnout. There have been a number of studies now that have shown that primary care physicians, by some estimates, as many as 50% of them are depressed. That tells you this is not an individual issue. This is a systemic problem. In fact, physician wellness has become the buzzword at many big healthcare organizations like ours, because we realize that unless our physicians are content with what they're doing, there's no way to then deliver good care. And the reason for the burnout is very simple. It's what I call the 4,000 clicks problem. 4,000 clicks is the title of this paper in the Journal of Emergency Medicine. Emergency medicine physicians in this study, in the course of their shift, clicked the button 4,000 times on the mouse. To order a baby aspirin was 8 clicks. Half a baby aspirin is probably 16 clicks. Admitting someone with chest pain is 132 clicks. And the bulk of their time was spent in front of the computer. My associate at Stanford has done a similar study looking at residents and medical students. It's very hard to tell when exactly they're with the patients because so much of their time is spent on the computer. And as I'll say, this is not their doing. This is not a choice they made to neglect the patient. It's just the way the workflow has evolved, and we must change this. So our biggest problem is red tape. This picture is from a book by a friend of mine who's an anthropologist at UCLA, and the book is called Red Tape. And this is a village land deed recording office in India. And you can imagine the ordeal of trying to go there and get something. Well, our red tape is much more organized, but it still is the bane of our existence. Now, the third reason why I think the exam remains terribly important is that there's an important ritual here, or something that I didn't quite understand till somewhat later in my career. When I was in Texas, before I moved to Stanford, I had a reputation as being interested in patients with chronic fatigue. Now, this is not a reputation you would wish on your worst enemy. I don't quite know how it happened. One patient led to another, and I was an infectious disease specialist. I wasn't unwilling, but these are very difficult patients. They have been rejected by their families very often, or disbelieved. They've had bad experiences with healthcare. They come to you prepared for you to be another physician in the long line who's disappointed them. And so I learned very early on that I could not do justice to a patient like that in a 40-minute new patient visit. So I'd give them the first visit entirely to tell me their story. I tried not to interrupt them. We know that the average physician interrupts their patient in 14 seconds. And if I ever get to heaven, it'll be because I held my peace for 45 minutes and let them tell me their story. And then I did the physical on the second visit, a much more leisurely physical exam, since there was nothing else to be done except the physical. And I remember in the first or second patient in this series, the patient still had a lot to tell me on the second visit. And I was beginning to despair, and I decided, I'm just going to launch into my exam. And we all have our ways of beginning the exam. I always begin by shaking hands. It seems so natural. And this hand is registering things like the warmth and the sweatiness of the hand and looking at the nails. And this hand slides over and feels the pulse. And then my hand slides up to the epitrochlear lymph nodes. And I am now in my ritual. It's a ritual that hasn't changed in 30-something years. It sort of happens, it just unfolds like rolling down a hill. And a very interesting thing began to happen. This voluble patient began to quiet down. And I had a very eerie sense that the patient and I had fallen back into some sort of a primitive dance, a ritual in which I had a role and the patient had a role. I didn't quite understand this, I confess, until I got to Stanford and began to talk to my colleagues in anthropology. My colleague, Dr. Costanza, was sitting there, and we actually wrote a paper about this. And they taught me, the moment I told them this anecdote, they said, wait, Abraham, you're describing a ritual. And they taught me that rituals are all about transformation. We engage in rituals to signal the crossing of a threshold. Marriage, take marriage, for example. We marry with great pomp and ceremony and considerable expense to signal our departure from a life of loneliness, misery, solitude to one of eternal bliss. I'm not sure why you're laughing. That was the intention. We have similar rituals for death. We have rituals for the passage of power. Well, the ritual of one person coming to another and telling them things that they wouldn't necessarily tell their spouse, their rabbi, their priest, and maybe this reflects my infectious disease training, but they'll tell you things that no one else will know. And then incredibly, they will disrobe and allow touch, which in any other context in society would be assault. This has all the trappings of a ritual. And mind you, it's a ritual that requires skill, very much like this picture of an Indonesian ceremonial sword craftsman passing this on to his apprentice. If it's not taught well, it dies. It just disappears. And I've found that most of our patients understand that there's a ritual. In California, I take care of all kinds of ethnic groups, and they all have very different beliefs about disease, about illness, but they all believe that if you're going to put them in a room whose furniture doesn't look like the furniture in their house or yours, and if you're going to wear the shamanistic white outfit with shamanistic tools in your pocket, and they're put into this absurd paper gown that seems to have a special tying ritual to it, that you then propose to do something more than a half-assed prod of their belly or stick your stethoscope on the gown. They're expecting something more. And if you don't do it, they're often dissatisfied. And my experience with the chronic fatigue patient was that I would wind up telling them exactly what they'd heard where they'd been before. Scott and White or Mayo, wherever they'd been, I would say the same things. This is not in your head. This is real. The good news, it's not histoplasma, it's not cocci, it's not cancer. The bad news is we don't know exactly what causes this, but here's what we should do. And I always felt that if they accepted my recommendation and sort of began a partnership with me towards wellness, it was because something in the exam, that ritual, had sort of cemented a trust, a transformation, if you will, that couldn't happen without that. Now, what is the transformation, you might ask? Well, so you do this ritual, what is the transformation? Well, I think it's an important one. The ritual preserves the personality, the embodied identity of the patient. It also says that your problem is not on an image somewhere, it's not in a slide somewhere. I'm going to locate it for you on your body. And it seems to be a necessary function, I think, in patient transactions. So I have the opportunity from time to time to travel to other medical centers, and because people know I'm interested in teaching at the bedside, I often get asked to make rounds, which I love to do, and I'll often throw in a little litmus test just to see how are they doing compared to how we're doing. And they're all, everyone's doing fairly well, but we're all struggling in the same places. And my litmus test is to say, demonstrate to me on this bedridden patient how you do an ankle reflex. And an ankle reflex is a little tricky to do. The way it's being done in this photograph is not how I would teach a novice. It's probably the hardest of the 3 or 4 ways you could do it. And the amazing thing to me is very often, no one in the room has a reflex hammer. Or maybe 1 out of 10 has one. And yet if you biopsied each of their charts, on every one of their patients, it probably will say 3+ ankle reflex, 4+ quadriceps, 5+ jaw jerk, etc. It's quite amazing. I like fiction. I even write fiction, for God's sakes. But I don't think it has a place in the medical record. And we actually have a situation now, I think, where large parts of the medical record represent repetitious cutting and pasting, and the physical exam, as far as I'm concerned, is totally unreliable. The appearance of checklists that allow you to click boxes, we have a reflex. We see a box, we want to click it, whether we've done it or not. And it's, I think it's a travesty, something that we have to get at. How do we begin? I'd love to hear some of your thoughts and solutions. At Stanford, one of the things we're doing is we're trying to develop a culture of going back to the bedside. We're trying to develop a culture of people being skilled at the bedside. And we're trying to say to medical students and residents, yes, we know you learned this in the first 2 years, but now we're going to show you advanced skills so that you can get really good, that we can put you down in the middle of a refugee crisis somewhere, and in the absence of all the usual tools that you have, you will do as well as anyone else who has the same skills. And that is something that people seem excited by, residents seem excited by, we're excited by. And we're hoping that by doing so, we'll bring back this sort of bedside movement, something that allows us to reduce error, keep us more happy, satisfy patients, and perhaps practice cost-effective medicine. Many years ago, William Osler said, "Every patient upon whom you wait will examine you critically and form an estimate of you by the way in which you conduct yourself at the bedside. Skill and nicety in manipulation, whether in the simple act of feeling the pulse or in the performance of any minor operation, will do more towards establishing confidence in you than a string of diplomas or the reputation of extensive hospital experience." I believe that even in this era of big data, when someone is ill, they are actually removed from the normal world, so to speak. They become fearful, they become infantilized, and there is a really important need for them to be in contact with a great healthcare system, very efficient, all those things, but also individuals who make them feel that they are being treated as individuals with unique problems. Peabody said many, many years ago, the secret of the care of the patient is caring for the patient. And I think that whatever changes come down the pike, that still has to be our operating philosophy. We have plenty of time left, but I'm done. I look around and I see a very distinguished number of colleagues in the room, all of whom I know will have great opinions and thoughts about some of the solutions. So thank you for being so very attentive. I'm grateful. We have 2 microphones, gentleman down here. Yes.
Thank you. So I'm an academic neurologist, and I think I'm in the field where we still do the physical examination,
Yeah.
not as much as we certainly used to, but the patients often say, when I start examining them, after about 2 minutes, they say, "Wow, nobody's ever done this much or even touched me for more than a minute or two." Yeah. And one of the concerns that I really do have is the fact that the medical students aren't looking at where the patient has pain. For example, we do an OSCE session where a patient has back pain radiating down the leg. The ones that do check things like strength and reflexes I'm happy with, but almost none of them actually look at the back, feel the back. Is there shingles there? Do the muscles feel tight? Is there an abscess there? And it's a real atrophy of skills. And I work at a good medical school, and I can't imagine how this is going to play out. It can't be a good thing because tests are ordered without any exam being done, or the exam is really useless.
Well, thank you for sharing that. I completely agree with you. In fact, we had a paper we wrote about what we call the flip patient. As you might know, we now have the flipped classroom where we no longer lecture in big lecture halls. We give students some of the materials that we think they need to watch, short videos, and then they come to the class to meet in small groups and discuss. Well, we're noticing that many of our clinical students have sort of researched the patient online before they see the patient in the emergency room. So they already think they know the patient. They're actually quite biased by what's been written before. And when they get to the patient, it seems almost redundant to actually do very much with the patient because they think they already have it all. And I think that's really quite critical. And I share your sense of how much patients appreciate it when we examine them. At Stanford, we have, as you can imagine, I'm sure at your place too, very complicated patients. Second liver transplant and now with a brain abscess and this and that. There can be 10 consulting teams seeing that patient, and I'm the primary attending perhaps. And the family might ask to see me, but too many syllables in my name, so they don't remember all that. They say, "I want to see that doctor, the one who examined me well," or examined me, period. Which leads me to believe that many other people just step in and say, "Well, your creatinine is this today, or that's happening today." And it matters to the patient, even if we don't necessarily need that information. I think the microphone is over here. Yes, ma'am.
Thank you very much. My name is Sabina Rashid. I'm with the Brack School of Public Health in Bangladesh, and I'm a medical anthropologist by training, so I really appreciate it. I just have a couple of points and a quick question to you. Often with patients in Bangladesh, trust came up as a big issue. So relationships and communication, not just about your day or where you're from, but how do we incorporate doctors not being dismissive of emotional, spiritual understandings about their own bodies. So patients who look at causations beyond the biomedical. Because you can still be a very good doctor, but you can be dismissive of other factors as the patients understand their bodies to be affected by, one. And two, in resource constraints, countries where you want to inculcate certain kinds of values and ethos, but how do you treat patients? So do we have to look at curriculum or content or additional training? Or, I'm just curious to understand what your thoughts are there. Thank you.
Yeah, I must say, sort of to deal with the last part of your question first, when I travel I trained both in Africa and in India, and have the chance to go back to both places, and I'm struck by how much medicine, especially in the corporate hospitals, the big corporate hospitals in India, looks very much like our care, with the same sort of inattentiveness, the same excess ordering of stuff. I don't know what to say about your first comment about trust, except to say that I think we do acknowledge that in our curriculum. For example, the whole notion of getting a spiritual history on the patient is something that's gotten a lot of purchase. Because how do you help this patient? How do you understand them unless you know what their stance is in terms of what this illness means to them in the grand scheme of things? And but I'm by no means an expert on that, and I'm afraid that's all I can say to that. Over here to Vivek. In case you didn't know, this is our Surgeon General. I'm very proud of him.
Thank you, everyone. Thank you.
And in academic internal medicine, we're especially proud because one of our own has become Surgeon General.
Well, thank you, Abraham. And I had a comment and a question for you. But first, just wanted to thank you for your inspiring words. I was just saying to Dave, who sits next to me, that you speak as poetically as you write. And it's such a joy to be able to hear you. And I read My Own Country actually at a very formative stage of my own life, and still remember how the lessons that you laid out in that book helped shape decisions that I made in my own life. So I thank you for that. The comment that I had is, as you were talking, I've been in this job for about 6 months, and I haven't practiced medicine while I've been in this job. But I was struck very powerfully by your talk, because it reminded me of what I miss most about medicine. And people have often asked me, since I started this job, do I miss practicing medicine? And I've said yes in vague terms without describing exactly what it is that I miss. But I miss that proximity to patients that comes from this very deeply intimate exam that one does. And as you were describing your exam, I remember many times when I would see patients, I wouldn't necessarily know what was wrong after taking the history. And I would start examining them, and there was something that was calming and soothing for me about the exam. And it was a ritual that I flowed into. It felt natural. It felt like I was connecting with the patient. And putting me in that different state of mind actually helped me to think in a way that allowed me to often better arrive at a diagnosis and treatment plan. So that was one comment I wanted to share. The question I had for you is that, I personally firmly believe that what you're describing in terms of getting back toward the exam and getting to the bedside more often during rounds is incredibly valuable for many reasons. But in an environment where administrators and even physicians and program directors are pushing about efficiency, they're pushing around issues of cost. While, I personally think that actually it helps us with efficiency and with cost if we are paying attention to the exam. Have you found pushback as you've tried to orient, more of a focus toward the exam from administrators? Have you had people demand data from you, saying, well, where's the data that shows me that doing the exam or training students to do the exam is more cost-effective or it leads to better outcomes in the end? I'm just curious how you've responded to that.
Well, thank you for stating that very eloquently. I really resonate with what you're saying. I think the exam is spiritual, and I feel bad for, training internists and having them emerge and not learn the beauty of that ritual. And my conviction is very much like yours, that when you're called to see someone who has abdominal pain, if your first reflex is to order an amylase and plain films or a CAT scan, and not go and see them, you're going to waste a lot of money and time. And you might only find out after all those tests come back that it's really not back pain but chest pain, et cetera, et cetera. So I really think that it remains true that when in doubt, go back and see the patient. And I think that the burden is on us, as you say, to try and prove that this is cost effective. My own hope is that the study I mentioned on medical error, I'm very hopeful that it will attract attention, not so much from my colleagues, but from the public. I think the public would be scandalized to know that we certify people as, physicians, as internal medicine specialists even, when no one's actually seen them examine a live patient in an exam setting. Our exams are all multiple choice questions because it was thought that the live exam is too fraught, too many, potential mistakes, and so the psychometric mafia took over, and, you write a multiple choice question and you're done, which to me is, an absurd way to test skills that are more complex than that. It's like the drunk who's lost their keys in the dark, but goes searching for it in the light because there's light, So I think you're right that there is some burden on us to prove that this is helpful. The thing that I think is really helping us is, I find, and correct me if you feel differently, but the buzzword these days is patient satisfaction. So much is weighing on that. And patients aren't satisfied by the sort of short attention spans we have. They're not satisfied by the fact that the moment they walk in, we're talking about discharges. They recognize that there's sort of a schizophrenia around this that we need to solve. So I'm hopeful that pressure from them, awareness of medical error, will all sort of conspire to change this. But I should say I had a very engaging conversation with Jim before he introduced me. And I think the AMA is doing some very exciting things because I think they recognize that, it's such a bad use of our time for the best trained person in the medical team to be also spending so much time doing clerical functions. It's not a good use of the time. And, to have a scribe is, to me, such a primitive throwback, We did that in the days of the Roman Empire. We had scribes. And to think we've come all this way to have scribes again, as I talked with David earlier, why not just in this ubiquitous technology era of ours, why not capture what really happens between physician and patient? Why not bill for what really happens? And why not code and have someone else capture the data we need rather than relegating it to us? But there have been some exciting developments if you wanted to speak to that, Jim, in terms of what the AMA is looking at.
Maybe Michael's here who leads this effort. I'll ask Michael to make a comment. Sure.
Over here. Thank you.
Thank you. So the AMA, and since 2012, has decided to try to have more impact. We would focus on three important areas: accelerating change in medical education, which I think is an important part of what we've been talking about, improving health outcomes, and our work around improving professional satisfaction and practice sustainability. And it's around that work and everything you resonated. You had me at hello. I mean, this was like the perfect presentation for the reason we want to do this work is to bring this remove all these burdens that Jim talked about in his open remarks that take away from what physicians want to do, which is caring for patients. And all the electronic health record, the documentation is all taking away from that work. And so we're leading an effort both to provide tools and resources to physicians to sort of improve their practices, to eliminate some of those, at the same time working on a larger sort of policy efforts to work with the government to try to pull back and align some of their metrics and not to continue to add many additional quality metrics and burdens and documentation that really don't do a whole lot to improve patient care. So it's an exciting time, and this was a great presentation, so thank you.
Thank you. Microphone down here, and then back there. How are we doing on time? Okay, thank you.
Hi, my name's Anne, and I really appreciated what you had to say.
Thank you.
I've been a nurse for a long, long time, and I think I was at my best when I did rounding with my physicians, and it was in the good old days when we had time to together go into each room and discuss the patient in front of the patient. And I'm curious with what you're trying to change, and I admire what you're trying to do. Where does the nurse fit in?
So, I think that you ask a very important question. I've always thought that it's very dysfunctional for us to train medical students separately from nurses, separately from physical therapy students, and then expect them all to sort of seamlessly come together somewhere down the line. And, I think there's a few schools, I see my colleague from San Antonio here, where we have made efforts there, I believe, to have nurses and medical students actually take classes together. I think Denver also has done that. So I think we need a whole lot more of that. And, again, I don't want you to construe my remarks as suggesting that the only person who can do this is a physician. In fact, in the AIDS era, I could not have been, anywhere as effective, but for the physician assistants, the nurse practitioners. It was our team that made all this possible. In many ways, they embody the very qualities that I think we've lost in medicine, and they really preserved, and the patients recognized that and went to them for that. So we have a long ways to go to integrate nursing education with medical education. In most places I know, it's still quite separate, and it's to our detriment. Yeah.
Ours too. I think everyone loses.
I'm sorry?
I said, I think everyone loses when we don't work together.
Yeah, thank you. Sure.
My name is Raymond Z. I'm a pediatric radiologist, and I used to teach physical diagnosis. I'm concerned that the rise of medical imaging has contributed directly to the atrophy of physical diagnostic acumen or skills. I can't tell you how many times I've examined an imaging study. I called a referring physician, asked for some history of physical, and they share with me they haven't seen the patient yet. I guess my question to you is, have you thought about the role of imaging, and have you thought of a strategy to impart on the medical students that imaging is a supplement? It shouldn't be the first step.
Yeah, I think that's a great question. I hope you're all I hope you're all able to hear that. But I think it's interesting how in our progress, so to speak, we've lost some very important social rituals that it turns out that were terribly important to us. So when I was a resident in training, and I think this is probably true of Vivek and David, every day we would troop down to radiology and show the images to typically a very wise radiology attending who had so much to impart. And the more information we gave him or her, the more they taught us that the image could reveal. And the moment we were able to retrieve our images anywhere in the hospital, our going down to X-ray stopped. And in the process, we lost a very important ritual. We lost a very important means of learning. Similarly, the nurse's station, where the charts were, even though paper charts were, not particularly fun to deal with, they represented an important place for people to come together and talk to each other rather than sending each other consults or emails. You could actually ask a question. And, the analogy for me is Southwest Airlines, apparently, I got this from Bob Wachter's book, Digital Doctor. For their dispatcher, they still have one person standing there at the gate whose job is to coordinate the dispatch. Every other airline has found it's much more efficient to have one person sitting at a remote location who gathers all the necessary facts and coordinates everything. But at Southwest, they get it done very well, in part because when there's a problem, you can turn to someone and fix the problem. You don't have to send a message, send a page, find them on the phone or talk to them remote. You're right there. And I think that kind of wisdom has to come back to us. I think T.S. Eliot said something to that effect, where is the wisdom we've lost in knowledge? And, you might paraphrase that and say, where's the wisdom we lost in all this data and the ease of acquiring the data? So I, for example, as attending, like to take the whole troop down to radiology because I think it's a good exercise and we inevitably get something, not just medical, but something social. And I think we have to, as we reinvestigate medical education, look at the rituals that were terribly important. A morning report, for example, is a very important ritual. Right now, I think there's a great danger it's happening at the wrong times, at least in my institution. It interrupts attending rounds. And there's just a lot of moving pieces that we haven't quite got right because we haven't defined how important the social roles are. So morning report to me is a chalk talk. And if it interrupts attending rounds and the ability for the attending to model good behavior at the bedside, then it's taking away something important. It has to be moved. So we're all struggling with all these various things. But my belief is that the pendulum is swinging in the right direction. I'm an optimist. And I think any industry that introduced computers went through this growing phase because they hadn't gotten the computers to work for them. They hadn't gotten the computers used to the social rituals that were in place, instead of having the computers force you into rituals that are not productive. And that's what's happened to us. So we have to sort of bring the arc back to where it was. One major problem, I think, is the electronic medical record. The electronic medical record, EPIC, is the one that rules, that has a hegemony, I think, is all about billing. It has nothing to do with the care of the patient. It's all about billing, and it's tremendous for hospitals who are trying to capture the last dollar. I think it's not a good research instrument. It's not a good record of what really happened, and something has to change there. And again, quoting Bob Wachters' book, he talked about visiting Boeing factory, and every individual in the Boeing factory is worried and is always keeping in mind the passenger on the plane and their life, and the fact that an error here could cost someone over there. I think the people who write electronic medical record software could give a hoot about that. Their attitude is, I'm writing you the software, it's up to you from here on, And we need a much, much tighter sense of purpose between these different individuals in order to make care happen well. And maybe this is a good note to end on. I think it's going to happen. I think that well-meaning individuals like yourself and the folks at the AMA and our Surgeon General and David and David sitting in the room who have such an interest in this, the collective efforts and the collective sort of intellectual power and the goodwill behind this, I think, has to bring it back to something that will become, computers will serve us and become indispensable, as opposed to indispensable and killing us. That's where we are right now. Thank you so much for being so very attentive. Thank you.